the world has gotten complex in lung cancer, and it does take an incredible amount of communication and coordination to execute the plan, I think, in the right way, especially with next generation sequencing and PD-L1, and how do we divide and conquer, and then how do we prioritize the information we receive back. Isabel, this is a patient who has both PD-L1, that comes back, as Sam says, within 24 to 48 hours. That's your first test that you get back. And if your patients are anything like mine, they're knocking down the door for Keytruda. They see the ad on television, and this is what they want. But this is a never smoker with a high chance of harboring an EGFR mutation. So how do you manage that? And do you wait for the EGFR test to come back before making decisions? How do you manage a patient like this?
So I think you raise an excellent point, Ben, and I echo what everyone else has mentioned so eloquently about EGFR testing. I think in a never smoker, if you have a PD-L1 of 50% or greater, it's very easy to get trigger happy and to want to offer them single agent pembrolizumab up front. However, I think you have to take a step back and think this patient is a never smoker. The likelihood of them having an EGFR mutation or ALK or ROS1 is possible. Maybe you want to take a step back and think, why don't we wait? Is there a way we can expedite this testing? This might be a point where I would reach out to the pathologist and I would say, this is my patient, she's a never smoker, she's symptomatic from her disease. What's the turnaround time for getting some EGFR results back? And have a discussion with my patient about that and encourage her to wait for the EGFR testing if she's relatively asymptomatic.
Yeah, and we'll go through why in a second. We'll present some data on how lousy a drug immunotherapy is for EGFR mutant lung cancer. It's quite incredible. Before we do that, we've had a lot of data recently on liquid biopsies. And are you using liquid biopsies a lot in your practice for genomic interrogation of these patients? Or are you still relying mostly on tissue?
So I think it's very institution driven. But if I'm seeing a patient as a consult that is very symptomatic from their disease and is a never smoker, that might be someone that I might offer a liquid biopsy on to expedite the testing to determine EGFR.
Yeah, so we've got data now just published 2 weeks ago suggesting that every patient with an advanced non-small cell lung cancer should have tissue testing, but no offense, Sam, should also get a liquid biopsy to expedite the genomic interrogation, and maybe doing them in parallel will expedite the result. Have you had a lot of questions from medical oncologists about liquid biopsies? Or
liquid biopsies are hugely challenging, right? What do we do with them? Where do they fit in the cancer treatment spectrum or diagnostic workup? So I have got a lot of questions. Interestingly, on the back end in the lab, it's the same process, whether it's the tissue or the liquid biopsy. I think it's just operational. So we have really streamlined our operations by reflexively testing virtually every patient so that we don't see a lot of liquid biopsy use because we get those results back on the chart. Now the question becomes, do we get additional information with the liquid biopsy? Let's set aside the timeline question. Do we get additional information, which is challenging? What we do know is if you get a negative result, you can't trust it. Right. We're looking for circulating cell-free DNA. Not all tumors are shedding, so if you get a negative result, you can't trust it. One of the things I caution, generally with molecular testing, a positive result, we've not had to worry about false positives. With some of these tests, we're pushing the sensitivities of the detections to the point where we now see we'll pick up a mutation in the peripheral blood. And is that a false positive, or is it tumor heterogeneity when you compare it to the primary tumor? Or do we have tumor heterogeneity and we're just seeing the more advanced where you've got now a driver mutation? I don't think that question is fully answered yet. And so the role of liquid biopsies is still to be determined. They're certainly gaining in popularity. I urge caution, and I encourage optimizing your upfront tissue specimen processing to get those results as soon as possible.
You're well versed in the liquid biopsy lingo.
Yeah.
So there's been a lot of so I think this is an ongoing discussion, and I agree with you. The sensitivities are getting so low with liquid biopsies that you're able to pick up on subclonal mutations, or what I call schmutz, and whether it's real or not. That said, I think that we are going to see an increasing, ever-present role for liquid biopsies in advanced stages, and it may be able to add additional information that was missed in tissue due to tissue heterogeneity or QNS or whatever. So I think we're just beginning to scratch the surface here.